Okay, for those who don't know me, where have you been? My name is Nikki Jamieson, so I'm going to talk to you today about moral injury. But before we do that, I'm very well aware we've been kind of sat on our bottoms for the last couple of hours, so I think it'd be really good just to get up for a few seconds and just stretch your legs a little bit, do a bit of a shake out. It's been quite a heavy content we've been focusing on this morning. Breathe in, by all means. Please do breathe out. I'm not very good at CPR. Okay, I'll take a moment to acknowledge the traditional owners of the land, wherever we are meeting today, both online and off. And I'd also like to acknowledge and pay my utmost respect to the veterans in Australia and in the room with us, those ex-serving members, those current serving members, the reserves, and those that we've lost who can't be here today. I would also like to acknowledge those with lived experience of suicide in the room. It's a very difficult topic, as Bernadette touched on earlier, and very difficult for those that watched Gwen's presentation yesterday. It's very raw and can be quite hard for people. So if any of this is triggering for you, please, as mentioned earlier, there is support available. I would like to acknowledge those with lived experience of suicide in the room. I am one of those people. So as you heard Bernadette mention earlier, I lost my veteran son to suicide in 2014. So since his death, I've been on my own suicide journey, and part of that was really investing my attention and energy in what suicide was. When I lost Daniel, I had no idea. I kind of knew the basics, but I wanted to know the whys. As every parent does, there were numerous questions that were unanswered for me. So I decided to do some research. Google is never enough, so I then became a suicidologist. So I studied for 2 years in suicide and suicide prevention and did a master's in suicidology, but that wasn't enough. So in my final year of my master's, I decided to do a PhD at the same time. So for a year, I was doing a PhD and a master's at the same time. Don't recommend it, please, anybody. I don't know how I'm actually stood here today. So I am about to submit the PhD, it'll be coming up very soon. So some of the findings that I talk about today will be in a published set of findings papers. I've also published a couple of papers that I'm hoping should be available at some point as well on moral injury, what it is, what it isn't, and what we can potentially do. And I'm going to briefly go over some of that today, because I know we're kind of in morning tea zone now, so people will be getting a bit twitchy. So I'll try and skim through as fast as I can and use the technology, which usually fails on me. So here we go. Oh, it sticks. Oh, there we go. Maybe I better not pull that. I might pull some stuff down that I really don't want to. Okay, let's go this way instead. So I don't want to concentrate too much on the statistics. We had these conversations quite intensive yesterday. The two figures I've put up there, the 56 was for the people who have been lost overseas in combat. The 465 that was echoed yesterday, these are the people we've lost to suicide. So quite significant. For me, the important number will always be 1. That person we have lost to suicide has to be the primary focus of our attention, and the veterans that we are losing, apparently we're losing around 1 every fortnight at the moment. Anecdotal data is telling us we're actually losing 1 a week, but they can't be confirmed for a variety of different reasons. So suicide is problematic. We wouldn't all be sat here if it wasn't. This is why we're all here today. We want to try and prevent, or at the very least, reduce suicide in veterans. Okay, so very brief overview. I probably should thank UNE and Suicide Prevention Australia as well for helping with the funding for my research. So very, very quick overview. It was a qualitative design. As far as I'm aware, I'm the only researcher in Australia who's looking at moral injury in this space, and particularly using a qualitative design. From my findings, which are all from veterans, so the findings that I echo are from the veterans that I interviewed. This is their voices, and I really hope that I honour those. Obviously, as part of the thesis, there's been intensive research done on the literature and evidence available and supporting moral injury, most of which comes from America. So Australia, hopefully this is an area we can actually lead the way in. We have got some research in this space. Lindsay Carey and Timothy Hodgson are doing some great work, and Tom Frame did some great work in this space a few years ago. And I believe Phoenix are doing a little bit of quantitative work, and Open Arms are doing a bit of quantitative work in this space. So if we can progress that, we may actually become the leaders in something. So anyway, I won't go into those too much. So when we talk about moral injury, we talk about, generally for most people, we want to be good. We want to be seen as doing the right thing. So when we talk about moral injury, it's when our moral codes, the very codes that make us, the codes that we've learned, that we've become accustomed to, that we've acclimatized to throughout our entire life, they make up our entire identity and shape our values and shape our actions. There are instances, particularly in defence, that those can be challenged. So I always kind of do this little bit of a test with people. For the clinicians in the room, you've probably seen this one before, so you know what's going to come next. So imagine you are this little cool dude with the question mark. You are the controller of this trolley. You've just got the call. This trolley is runaway. Let's call it a juggernaut. Let's be a bit, melodramatic here. You've got a juggernaut coming your way. You've got two options. Do you divert that juggernaut to track A with the one person on it, knowing full well that person is going to die? Or do you divert it to the second track with 5 people on it? So my question is, do you sacrifice 1 for 5 or 5 for 1? So show of hands, who would divert the trolley onto track with the one person? And who would divert the trolley onto the track with 5 people? That's usually the response. What if I told you that person on track A was your child? How does that change things for you? I imagine for most of you, you will get a moral response. You will have just that tiny, minute gut feeling. That is a moral bruise. Accumulation of those moral bruises that may be exposed in events in ADF and experienced in ADF can accumulate and cause major moral traumas. When those manifest, we have problems. So, as I've said, I've got a couple of publications. They're the ones on the right. There's a few of them that are in progress, so they're going through the publication process at the moment, if anybody's interested in reading them. I was actually supposed to remove these animations because it makes it a really big file, but whatever, so be it. So as part of my work, I actually went through all of the literature and wrote up a concept analysis that actually defined what moral injury actually is. Part of that process was looking at all the definitions. Now, even now, today, we still don't have an agreed definition. Most of the definitions were looking at moral injury from that psychological lens, which is very, very limited and doesn't really capture the biopsychospiritual and existential issues that are attracted to moral injury. So I couldn't find a definition anywhere that I was happy with. So I created my own, and I published it. So I have actually redefined moral injury, which is the American term, to moral trauma, because I believe that the notion of injury suggests that you can heal, stick a cast on it, stick a band-aid on it, everything will be right, mate, off you go. Trauma for me is a bit more lifelong, as is moral trauma or moral injury. I'll use the two terms interchangeably. Moral trauma is lifelong and you don't ever heal from it. And that's not a bad thing. What does happen, though, is you learn to navigate your new normal. You learn to live in this new normal, and you learn to grow from this new normal. You learn about your new identity, and that's when we bring in acceptance and forgiveness, which I'll talk a little bit later about. So moral injury in its basic form is a violation of our core moral framework, our core moral beliefs, everything we value that fundamentally underpins our actions. So it can be by, witnessing or acting in ways that violate a moral code. It can be by a moral transgression of some kind. The number one underpinning notion that impacts our veterans, particularly in regards to moral injury, is betrayal. Now, the literature will tell us that moral injury consists of guilt, shame, and self-condemning behaviours, which can lead to suicidality. My literature is saying we actually need to put a hell of a lot more focus on betrayal. It's absolutely key. It's an action and a symptom of a moral injury. Why do people get moral injury? Well, there's a number of reasons, but in a military and ADF perspective, one of the issues is, and it has to be done, obviously, my son went through the same process when he did Kapuka, his whole entire moral framework was stripped down. His whole civilian identity was stripped away from him as part of the training process and re-embedded with military moral codes, values, principles, and the framework. For some, that works fine. For others, it doesn't. We will always have our core values, and they cannot be changed. And it's often those that are very, being challenged and lead to moral injury. So some of the issues we have with moral injury at the moment are some of the contemporary challenges, and some of this has been recorded by the veterans that I've researched. Things like green on blue attacks, things like we're not too sure, what terrorism is or who's a terrorist or what this enemy looks like anymore. We have drone warfare. There are so many challenges that weren't experienced in World War I and II. So, contemporary warfare is looking very different. But the number one causes for moral injury in the groups that I've spoken to and the veterans that I represent, for females especially, military sexual trauma. So 90% of the females that I spoke to had been sexually assaulted in some way. And it's that betrayal of leadership that is the number one factor for moral injury and causes the most damage in our veterans. Because you're trained to be a team player. You're trained in that team ethos. You are trained to support and conform with your leadership. When your leadership or the system turns its back on you, that is a huge moral injury. And we are seeing this playing out now, today. The release of the Breton Inquiry, that is an absolute classic example of a platform for moral injury to fester. Leadership has been considered as letting them down. The system pretty much, sacked them. A system that was considered to be supporting of them has significantly betrayed them. We've noticed the manifestation of moral injury through a 500% increase in crisis calls and a spike in suicide since the Breton Inquiry report. So this is how it manifests. People don't know how to reconcile these emotions and these feelings. They feel like they're a bad person. Everything's gone. Their whole identity has been shattered. So these are some of the feelings that often associate with moral injury. The predominant one is, I'm no good, I've got no purpose, I'm worthless, I'm hopeless, there's nothing I can do, nobody wants me, nobody loves me, they see this image of me, I don't belong here anymore. Now, I know some of you, maybe the psychologists in the room will be looking at those and thinking, that actually sounds like PTSD, but wait, there's more. Now, moral injury, as I said earlier, it's not something that suddenly just happens to you. It accumulates over time. Now, there aren't enough assessments or measurements available to tell us how long that might take. And it doesn't necessarily have to be one event. It can be accumulation of small events over a period of time. Or it can be that one order that you're given, to kill somebody, for instance. And it just doesn't feel right, and you don't reflect on it until you become a civilian, and that's when moral injury and the symptoms will start to manifest. So it can be quite difficult, particularly in a treatment and assessment space, trying to navigate, because we just don't know at the moment. So early intervention is definitely the key. Now this is my attempt at, a bit of graphic design. Not very good. If there are any graphic designers in the room, please put your hand up. Oh, hello. Oh, fantastic, awesome. Yeah, I'll get your number later. So basically I was trying to put moral injury on a bit of a continuum. So depending on what your moral framework's like and how many incidences what we classify as low harm or high harm will generally determine how likely you are to suffer a moral injury. Now, bearing in mind, if you're a sociopath or if you have a strong diagnosis of narcissistic personality disorder, you will not encounter a moral injury. You have to have a strong moral framework to be vulnerable to a moral injury. So for those psychs in the room who want to do a bit more research, have a look at conscientiousness and neuroticism and moral injury. That would be a really interesting spot to do some working. These are the key facets of moral injury. This isn't my diagram. This is from William Nash, who's one of the key authors in this space. And again, I can see people thinking, hang on a minute, this looks like PTSD. Kind of, but no. It needs to be a completely separate construct, and there's a lot of theory and arguments about that. And hopefully the next version of the DSM will bring back moral injury, because it was in the DSM-4, got removed out of the DSM-5. Hopefully the DSM-6 will bring it back. Here we go. This is a good one. This identifies the differences between PTSD and moral injury and where the overlap actually is. And this is really tricky for clinicians, particularly in Australia when we hardly know anything about moral injury and we've got no real rigorous and valid assessment tool, so we can't really assess for it either particularly well. But PTSD is often considered that fear-based response. Moral injury is considered more of that shame-based response. It's not a fear of something that's going to happen, it's a fear of that person I've just become, that bad person. Now, here we go. For the people who are arguing whether it's PTSD or moral injury. Now, I'm not a neurologist, I'm not a psychologist, I'm a social worker by trade, but there have been tests and there are clear differences between how the brain functions and how it activates in certain areas of the brain for somebody with PTSD and somebody with moral injury. Hence why we need a completely separate construct. That's just some of the issues that were picked up in Litz's study, but I don't think we've got too much time. Basically, what I was saying there is 90% of ADF members have experienced some kind of traumatic experience compared to 73% of the national population. So my question was, most of those will be diagnosed with PTSD. Is it really PTSD? There are varying figures around those people who go through a PTSD treatment. I've seen them up to 60% that go through a full and rigorous PTSD protocol, still have PTSD at the end of it. In Litz's study, so he's one of the key authors in moral injury, 2/3 of people who go through a PTSD protocol fit the criteria for moral injury and don't recover from PTSD. So there's still a lot more work to do in the PTSD moral injury space, but notably moral injury can lead to PTSD. So again, it's very difficult for clinicians to tease the two apart. That doesn't work the opposite way around. PTSD will never lead to a moral injury, but moral injury can lead to PTSD. So these are some of the assessment tools. Nash, again, he was one of the instigators of these tools, as was Courier later on. Again, it's difficult because validity and specificity and rigour hasn't really been measured too well. There's critics on all these assessment tools. My theory is to use more collaborative assessment processes. In suicide prevention, the STARS approach, I'm not sure if people are familiar with that, it's much more than a simple tick and flick process. When you're dealing with a human condition, we can't just use a tick and flick process. And we do it a lot in suicide prevention, and Richard Bryant talked about it yesterday. There is no single assessment tool available on this planet that will accurately predict suicide. But in light of Christine Morgan's comments yesterday about looking at those gaps in between and those tipping points between suicide ideation and somebody making an attempt, there is actually some work going on in Ireland by a wonderful suicidologist that I have a bit of an academic crush. He's called Rory O'Connor. I suggest you have a look at his intentional, motivational, volitional model for suicide. He does actually have a look at some of those gaps. Okay, getting back to moral injury. So treatment approaches. There are a few that are being tested, but one of the biggest that is coming forward is anything to do with acceptance, commitment and forgiveness. Now there's quite a bit of research coming up, even in Australia. Timothy Hodgson and Lindsay Carey are some of the key moral injury authors when it comes to connecting moral injury with spirituality and religion. So that is actually proving really positive results in really embedding, the support around spirituality and religion. So, we use our padres. Let's see more of that happening. Or whatever people want to ascribe to, whatever their higher being is, but we're finding if they can lend themselves to something other than themselves and help them feel good again, that is definitely helpful. And we kind of touched on it yesterday with Dr. Caldecott about the psychedelic drugs and how they take the mind to a higher place. If we can somehow, put those together, who knows? Again, we could be leaders in this space. Okay, so walking forwards. Now, this is what my veterans have said that they needed to help them move forwards in life. So, a lot of the research says, let's just throw adaptive disclosure at them. Oh, yeah, an impact of killing treatment. Let's just keep throwing treatments at them or medication. Our veterans are saying, no, we actually want the choice. We want to be able to choose relaxation or yoga. We want to be able to choose medication. Not all medications work for us, but fundamentally, we want that choice. They've been disempowered for a system for a number of years. Let's re-empower them. Let's give them those options. That's not a difficult recommendation. So that's a few of those, and I will be doing 3 findings papers, as I've said, that goes into these in much more detail. This is only a selection of the recommendations that I've chosen for here. I've actually drafted over 50 recommendations, which will be available in my thesis. Fundamentally, it covers everything from data to, I'm going to really highlight this, training. I'd like to see, and I've just started developing a training model in moral injury, I'd like to see training throughout any kind of engagement with veterans, be it defence, be it DVA, be it families, community, whoever engages with veterans, let's get the training out there. But it's also important to know that moral injury doesn't just impact veterans. Moral injury is across your first responders. We're seeing it in law, we're seeing it in teaching, we're seeing it in veterinarians and veterinarian assistants. And with COVID last year, we've seen an absolute explosion in the literature on moral injury, particularly overseas when countries have had to turn away people to die. That's a massive moral infringement. So the veteran space has kind of, quietened down a little bit through COVID. But now I'm back, it's getting up again. So part of the, approach for walking forwards as well with veterans is actually looking at transformation. We keep talking about identity and what that looks like. So I actually developed a transformation model specifically for moral injury. Now, I've not published it yet, so I can't really put it on here, but if anybody wants a copy of it, please feel free to email me. And that's basically about acknowledging the injury. As a clinician, this is probably really relevant, acknowledging sitting down with your client and acknowledging that injury and letting them acknowledge the experience as well. And then it's about actually going through a process of reconciliation. Now, that reconciliation process in my model actually involves a process of reclaiming the experience, reframing it into something positive, and repurposing. Again, it's drawing on that purpose and meaning that we've spoken about quite a lot as well. If we can do that, we've put veterans in a good space into being able to move forward. It's about giving them purpose and meaning, as I've said. Peer support is one avenue as well, but we just really have to be careful and make sure the peers are actually trained well and not suffering their own psychosocial problems at the time, because that becomes a bit tricky. So this is more for the civilian sector, because we're very well aware there's that civilian and military divide, and this is about trying to work together and educating civilians in understanding the veteran process, but also, helping veterans to liaise and contact and connect and engage with civilians as well, because, some of us aren't so bad. We do have some pretty good programs out there occasionally, but this is some of the stuff that veterans were telling me they would like to see, in a civilian sense as well. That picture in the top left corner, that's actually me and my son Daniel. He just graduated and marched out from Kapuka in 2012 on that one. So if we can be a bit more veteran-centric, in fact a lot more veteran-centric, and tailor around the person in their environment, and this is my social work speech talking, the person in their environment, and it has to be a systems approach. Whatever systems impact on our veteran, be it individual, family systems, DVA, defence, education, we have to be focusing on them and bringing them together like we saw in the WASP presentation yesterday. It really does need to be that almost case management, team around the veteran approach. So I'll back up that recommendation. Another one that Gwen mentioned yesterday, which was also part of my recommendations in suicide prevention, is postvention. So defence and DVA have very little in the space of postvention. Suicide prevention, as far as I'm aware, is a quick tick and flick process that's usually conducted online once a year. Sorry, that's not good enough. We need a lot more than that. We actually need some real-time experiences, and we actually need suicidologists in there, working with people to deliver that training as well. A tick and flick is never good enough in suicide prevention. So they're pretty much my recommendations. That's a different slide. But anyway, they basically looked at, as Christine mentioned yesterday, a seismic shift. And that's what we need in both defence and DVA. A massive seismic shift, particularly in culture, particularly in training, in recruitment, in data, in research, and in practice. If we are going to address moral injury, we need to address those underlying factors that enhance the risk of moral injury. Kay touched on some in her presentation. Betrayal is a huge one. Betrayal by the system that we've seen in Jessie Bird's case. That was also my experience as well. It was also the experience, of families who are well noted in the media, Julianne Finney's and others. And this is what has underpinned the huge push for a Royal Commission. It is this feeling of betrayal and injustice. Families and veterans are not being heard, and this has to change. We are never going to make the change by doing the same thing over and over, Einstein's definition of crazy. So if we reduce the acts that create the platform for the abuse and betrayal to occur and promote much stronger transparency, accountability, and consequence for when it happens, we will reduce moral injury. And in turn, we will reduce veteran suicide. Now, I'm just going to go for a quick what we know, but you can ask me questions. That's pretty much it. Unless you want me to talk about the cost effectiveness of suicide and how it costs us 1.6 billion a year and how that money could really be spent in early intervention. But anyway, that's me. Any questions? Oh, thank you.